This program is brought to you by Emory University.
Thank you everyone for joining. It is my pleasure to introduce Dr. Muralidhar Padala, and thank him for being the first one to help us do these cardiology grand rounds virtually. Dr. Padala is an associate professor in Division of Cardiothoracic Surgery here at Emory, and also holds a faculty appointment in the Department of Biomedical Engineering at Georgia Tech. He's also the Director of Structural Heart Research and Innovation Program here at Emory. Dr. Padala graduated with master's and PhD subsequently from Georgia Tech, and he's been very interested in mechanics of valvular heart disease and development of surgical techniques. And he's going to talk to us today about addressing functional MR in heart failure patients in the current era. Please, just a reminder to please keep your mic on mute, and then if you have questions at the end, you can just unmute. I'll turn it over to Dr. Padala.
Good morning, everyone. Thank you, Dr. Mehta, for the introduction, and Dr. Patrick Gleason for the invitation to present the Heart and Vascular Grand Rounds. So my topic today is on current opportunities in addressing functional mitral regurgitation in heart failure patients. So being a faculty on the research side, my intent is not to tell you what to do, but to pose questions from the clinical side and introduce to you some of the research that we are working on and attempting to answer some of the questions that are currently relevant to this topic. These are my disclosures, and I will not be discussing any off-label use of devices or drugs in this talk. This is a typical functional mitral regurgitation patient that you may be seeing in your heart failure clinic. They have dysfunctional ventricle that is not that has a poor ejection fraction. You have tethered mitral valve leaflets and relatively moderate to severe amount of regurgitation that goes through the ventricle into the left atrium through the mitral valve. The underlying mechanisms associated with functional mitral regurgitation could be several. The geometric mechanisms, which is that in these patients, you have a dilated and dysfunctional ventricle that continues to remodel post an ischemic or continued cardiomyopathic process that results in tethering of the valve, and regurgitation has been established several decades ago and is cited almost in every talk associated with functional mitral regurgitation. However, there are dynamic mechanisms as well, where the dynamic motion of the ventricle and its interaction with the mitral valve has also been shown to play a significant role in determining the pathogenesis of FMR, despite the lack of some of the geometric mechanisms that have been traditionally established over time. However, irrespective of the mechanisms, the three questions that I would like to address today are: does functional mitral regurgitation really contribute to worsening heart failure? This question emerges from the simple statement that FMR is actually a ventricular disease, and it may just be an indicator of worsening heart failure, but not contribute to worsening of the heart failure. The second topic I will very briefly talk about is whether ventricular approaches to managing FMR currently work, which include guideline-directed medical therapy, CRT, and revascularization in patients in whom it is possible. And finally, get to more of the research on a topic that we have conducted quite a bit of research, is direct mitral valve approaches for functional MR, their efficacy and their drawbacks, and the potential to improve upon both transcatheter and surgical approaches for functional MR. So starting with the first question, which is, does functional mitral regurgitation contribute to worsening heart failure? The paper or study which is cited the most on this topic is the study from Mayo Clinic that was published in 2001, where 303 patients who have had a previous myocardial infarction were followed to 5 years and segregated into patients who have mitral regurgitation of moderate to severe MR, and those who did not have any regurgitation. At 5 years, the patients who had mitral regurgitation had a 23% lower survival compared to the ones that did not have any MR. And this reduction in survival remained, or IMR remained, an independent predictor of survival despite controlling for diastolic dysfunction in these patients, other comorbidities, extent of coronary disease, or every other variable that had differed between these two groups of patients, indicating that yes, functional mitral regurgitation does have an impact on reducing survival. The same group in a subsequent study prospectively recruited similar patients and investigated the onset of congestive heart failure or signs of congestive heart failure using the Framingham criteria to look at how does heart failure progress over time in patients who have MR versus who do not have MR. And what they found is that patients who have MR tend to develop heart failure symptoms quite a lot more than the ones who do not. And in a third study, this type of adverse effect of functional MR on cardiac remodeling and survival was shown to, or poor survival was shown to be equivalent in patients who have ischemic cardiomyopathy versus who also have non-ischemic dilated cardiomyopathy. This clinical data, even though it demonstrates the adverse impact on survival and heart failure progression, one of the things that is currently unknown in the field is what is it that mitral regurgitation is truly doing to the myocardium at the functional level, structural level, and probably even at the transcriptomic level. That remains currently unknown. So we began our work trying to understand this exact topic. So we went to the laboratory to develop a preclinical model where we can understand the impact of mitral regurgitation on the remodeling of the ischemic LV when we control for the severity of mitral regurgitation and also control for the extent of ischemic damage to the ventricle. So this work was conducted by my research fellows, Dr. Onohara and Dr. Kono, where they developed a rat model of controlled ischemia or infarction and controlled mitral regurgitation. And the methods used were as follows. On the left side, you're looking at the traditional method, which is used for a myocardial infarction, which involves ligation of the left coronary artery, which results in a left ventricular infarction of about 40% of the left ventricle. On the right side, you're looking at the mitral regurgitation. So we induce mitral regurgitation by introducing a needle into the beating heart, and under transesophageal echo guidance in the rat using an intracardiac echo probe, we could advance the needle in the beating heart from the apex into the mitral valve, creating a well-defined hole in the anterior leaflet, which results in a regurgitation jet, which could be confirmed with both color Doppler and also spectral Doppler imaging. And in these animals, we could see after the induction of mitral regurgitation, we could see significant pulmonary vein flow reversal. So this is a video which depicts this procedure. So in these rats are under anesthesia. We perform a left thoracotomy and place a purse string. After that, under image guidance with an 8 French intracardiac echo probe, we are looking at the 2-chamber view of the heart and advancing the tip of the needle into the mitral valve. And we, in real time, we can look at the creation of mitral regurgitation. So upon confirming that at baseline, these animals had similar cardiac dimensions and cardiac function, we induced these the cardiac pathologies, following which we confirmed that the myocardial infarct area was similar between the 3 groups. And the 3 groups that we had investigated were animals that only had an infarction, that did not develop any mitral regurgitation, animals that had an infarction but had early onset mitral regurgitation, and animals that developed had an infarction, had significant remodeling of their ventricle, and developed or were induced with functional MR at significantly later stages. The regurgitation fraction that we had measured from these animals after 2 weeks after inducing the MR upon stabilization of hemodynamics, you can see is also similar between the groups. So this is the experimental design. We took 36 rats, performed baseline echocardiography, induced a myocardial infarction, let them survive to 4 weeks, 2 to 4 weeks. After their hemodynamics have stabilized, we went back in one group of animals and induced MR, which is the early MR group. And in the late MR group, we let them go to 10 weeks and then introduce mitral regurgitation. After inducing MR, we performed biweekly echocardiography in all of these rats until 20 weeks, which is equivalent to about 10 human years. And we performed invasive pressure volume loops and used the hearts explanted from this animal model to understand the biological processes that may be happening. So this is my first set of data. The red line shows the group that only had an infarction and did not develop any mitral regurgitation over the 20 weeks. The blue line is infarction with early mitral regurgitation, which is at 4 weeks. And the green line is infarction, late mitral regurgitation that was induced at 10 weeks. So this data on the y-axis shows the end diastolic volume. What is clear is that in the animals that did not have any mitral regurgitation, the rate of change and the magnitude of increase in end diastolic volume is a lot more gradual compared to the other two groups. As you can see in the blue line, in the early MR, once we introduce mitral regurgitation, the rate of change of EDV significantly rises, and also the magnitude at each and every time point seems to be significantly higher than that in the rats that did not have any MR. Similarly, when the onset of MR was delayed to about 10 weeks, we still see the same observation, which is that upon onset of mitral regurgitation, the volume overload associated with the mitral regurgitation increases the end diastolic volume significantly after the onset of MR, and it continues to do so until the end of 20 weeks. So if we had extended this to maybe 40 weeks, what we would see are significantly dilated ventricles compared to the ones that did not have any mitral regurgitation. The importance of looking at elevated EDV is that it has been a predictor of survival and mortality in these patients. Thus, the presence of mitral regurgitation seems to have an adverse effect on the end diastolic volume. When we look at the sphericity index, which is, as we all know, is a good indicator of myocardial wall stress, what we do see is that the ventricles with mitral regurgitation are quite spherical compared to the ones that did not have any mitral regurgitation. And you can clearly see that in the blue line with the increase in sphericity after the onset of MR, and in the green line, the increase in sphericity after the 10-week point where MR was introduced. What we saw from an end systolic volume standpoint is that there is a rise in the end systolic volume after inducing MR, but that was not statistically significant, indicating that the systolic dysfunction or the effect of mitral regurgitation on systolic dysfunction may not be revealed in this time point that we had looked at, which is a 20-week duration. And this was reflected as well in the ejection fraction, too. However, it should be noted that ejection fraction is not a very good indicator of ventricular function in these animals that have mitral regurgitation because of the pop-off valve effect that mitral regurgitation has and the uncoupling of end systole from end ejection in these patients. So what we had done was performed invasive pressure volume loops with preload reduction in all of the animals that were terminated at the 20-week time point. What we do see on the left side is a representative PV loop where we can actually see a rightward shift in the animals that had mitral regurgitation compared to the animals that only had an infarction. There was a significant reduction at 20 weeks in the end systolic pressure volume relationship in both the MR groups compared to the no MR group. And when we used an index, DPDT max normalized to the preload, we do see that there is a significant reduction in the contractility in the MR groups compared to the infarction-only group at the 20-week time point. When we look at the diastolic function, what we observe is that in the initial period, there is a rise in the EDP, which gets normalized as the ventricle continues to dilate. But at 20 weeks, we saw that in the early MR group, there was a significantly elevated EDP compared to the group that was induced with late MR, though we do not have an explanation as to why that would be the case. But here, what we do see is that in the late MR group, there is a high variability in how the EDP measured at 20 weeks looked like. And we could not see any differences in the end diastolic pressure volume relationship between these different groups at termination. When we explanted the hearts and weighed them, we began first by weighing the animal, then obtaining the tibial length and the heart weight. What we do see is that at the time of explant of 20 weeks, the hearts that were explanted from the animals that had mitral regurgitation were significantly higher compared to the ones that did not have any mitral regurgitation. And when we normalize this heart weight to tibial length to consider for growth, what we still see those significant differences between the groups. Here is a histopathological image of a representative heart from each of these groups upon termination at 10 weeks. And there are a couple of things which could be clear. The first thing is that this is an MI. The top right is an MI only group, and the bottom two are with MR. What we see is the significantly larger ventricular cavity in the MR animals. The second thing we see is that the infarcted region is thinned out a lot more, which is also expected because of the stretching effect that the increased volume overload could have on these hearts. And when we look closer, and this photograph doesn't show up that clearly, which is why I indicated it with these yellow markers, is that the myocytes are a lot more stretched out and thinner in the hearts that had mitral regurgitation on the right side compared to the ones that did not have any mitral regurgitation on the left side. Based on these ultrastructural findings, we then performed RNA sequencing of some of the hearts because we wanted to understand how the MR would impact left ventricle. And generally, what we would see is that the gene expression in groups that have had mitral regurgitation would be quite different and distinct when we perform a principal component analysis compared to the animals that did not have any mitral regurgitation. So we looked at various signaling cascades that could be involved in the processes. And some of the most prominent ones, or the ones that had the highest score, are shown here. At about 2 weeks, the pathway that was most upregulated was the P53 pathway, which is a key regulator of cardiac transcriptome and plays a huge role in maintaining the tissue's ability to maintain homeostasis. And it has also been implicated previously in the development of early stage hypertrophic signaling and is also associated with oxidative damage. What we see in the subsequent weeks at 10 and 20 weeks is that there is a significant accumulation of oxidative stress response in the myocardium. And this has parallel changes in the cytoskeleton of these cardiomyocytes, or the genes associated with the cytoskeletal remodeling. This is quite interesting because not too long ago, Ben Prosser's lab from the University of Pennsylvania has demonstrated that when the heart is under chronic mechanical loading or abnormal hemodynamic stress, and the myocytes are stretched out, that induces a change in the microtubules in the cardiomyocytes, and microtubule tyrosination has been associated with the accumulation of reactive oxygen species in these cardiomyocytes, and that could actually lead to their improper contractility over time. We are yet to validate in these RNA sequencing pathways from a protein standpoint what are the different pathways involved, but that is work that has not yet been completed. So based on this first set of data that I have presented to you, we do think that mitral regurgitation has a worsening impact on cardiac remodeling, whether it begins early or late. The mitral regurgitation induces geometric and both ultrastructural remodeling of the myocardial tissue. And we have provided some preliminary insights into the longitudinal signaling that could be occurring over time, and which also changes over time, which could be quite important in understanding not only the impact of various different drugs or identifying different drugs to inhibit this remodeling, but also to understand what could be the opportune time for intervention in these animal models. However, that is work that needs to be continued. Currently, we are working on both a rat and the pig model of reversible mitral regurgitation, so that we can try to understand how does timing of FMR reversal impact some of these biological pathways as we continue to validate them at the protein level. Which makes me go to the next discussion point is, do ventricular approaches for FMR work? So the current concept that functional mitral regurgitation is a ventricular disease has led to the development of concepts that you should attack the ventricle therapeutically so that you can relieve the functional mitral regurgitation. So the three approaches which are traditionally used and continue to be the first line therapy for functional MR are guideline directed medical therapy, CRT, and revascularization. Though I will not go into the depth of guideline-directed medical therapy, which is quite established, one of the striking things in guideline-directed medical therapy is that there are hardly any randomized data sets or very controlled data sets on the impact of medical therapy on a functional MR, except for very recent work that has started to emerge, where medical therapy is being used as the control group in testing various different transcatheter approaches, and the impact of guideline-directed medical therapy on functional MR is being investigated. Irrespective of the drugs that are used, the primary approach to reducing functional MR with medical therapy is to change the hemodynamic loading on the mitral valve by increasing the closing forces or reducing the tethering forces by potentially initiating some remodeling or reverse remodeling of the left ventricle. So the use of inotropes can elevate end systolic pressure, but long-term support with dobutamine or milrinone is quite challenging in the outpatient setting because of the need for intravenous access. Diuretics have been used where you can reduce the left atrial pressure and also reduce the end diastolic volume. By reducing the left atrial pressure, we can increase the transmitral gradient for a given left ventricular pressure. But also by reducing the amount of blood filling the ventricle, by reducing the preload, we can have a reduction in the EDV, which could potentially reduce the tethering forces to an extent as well. The third group and the fourth, which are the most commonly ones used, are ACE inhibitors and ARBs, which have a vasodilatory effect and thus can initiate afterload reduction, but also induce reverse remodeling of the ventricle, which could be quite beneficial. When we look at the data on the impact of GDMT in patients with moderate to severe mitral regurgitation, one of the most recent trials which stands out is the COAPT randomized controlled trial, where GDMT was optimized in these patients, and a vast majority of these patients also received CRT. What we see is that at baseline, about 100% of the patients were in 3 to 4 plus mitral regurgitation. And at 24 months of treatment of these patients with medical therapy, you still see that about 56% of the patients still continue to have 3 to 4 plus mitral regurgitation, whereas the rest of them had reduced regurgitation of 1 to 2 plus. This does not entirely mean that all of the patients, only some of the patients reduced and others maintained, but there could be some patients who also increased in their regurgitation severity over time. When moving to cardiac resynchronization therapy, the mechanism associated with using cardiac resynchronization therapy to reduce functional mitral regurgitation is that synchronizing the different parts of the left ventricle and their contraction could be quite useful in restoring the valvular ventricular continuity or valvular ventricular dynamism, such that the papillary muscles would work in sync and potentially reduce the dyssynchrony, and that would result in better closure of the mitral valve and a better systolic geometry. Also, cardiac resynchronization therapy has been hypothesized to improve the closing forces by increasing the contractility, but also by inducing reverse remodeling of the left ventricles. There are several studies which have looked into cardiac resynchronization therapy and its efficacy in functional mitral regurgitation. And I have chosen one study which has provided a very in-depth analysis and looked at several patients at 4 different centers that had adopted cardiac resynchronization therapy as an FMR therapy. What is interesting is that when you look at each of these centers, the baseline mitral regurgitation in a vast majority of these patients was about 54 to was in moderate to severe range. And at follow-up, which was at 12 months, you would see that about 50% of these patients had neither change in their mitral regurgitation or worsening of greater than 1 degree of their mitral regurgitation, whereas the other 50% had some improvement. Altogether, what we can gather from this is that this slide indicates that there is actually no reverse remodeling at 12 months after the onset of cardiac resynchronization therapy, depicted here as lack of change in end-diastolic dimensions and systolic dimensions or ejection fraction. What this indicates to us is that both guideline-directed medical therapy and CRT could have a role in reducing functional mitral regurgitation in some patients, but not every patient in heart failure could be responders, and FMR continues to persist in these patients despite the use of these therapies. Now, in patients who have been indicated for revascularization, does revascularizing the myocardium in patients who have viable targets enable the reduction of functional MR by restoring their myocardial motion? Unfortunately, the data seems to indicate that it does not. It is quite well known that even though there is a lot of benefit in revascularizing these myocardiums, the extent of recovery of the myocardium post-revascularization depends upon the extent of damage in the myocardium and the extent of hibernating myocardium versus dead myocardium. There are some studies which look in a randomized fashion at comparing coronary artery bypass grafting with coronary artery bypass grafting with mitral valve repair, at understanding at 12 months what is the change in the mitral regurgitation fraction. So the first study I show on the left side is a non-randomized study that was first published from Cedars-Sinai, where they have looked at the change or reduction in mitral regurgitation at an average of 412 days after either coronary artery bypass grafting or a combination with mitral repair were performed. What they observed is that coronary artery bypass grafting alone did not really change the mitral regurgitation grade, whereas as expected, when you perform a mitral repair, there would be a significant reduction in mitral regurgitation. Subsequently, there was the RHYME trial, which was performed in Europe, where they looked at a similar population, which is CABG and CABG plus MVR. And what they found is that mitral regurgitation persisted in these patients with coronary artery bypass grafting alone, but not the ones with mitral regurgitation. In the past decade, these studies comparing coronary artery bypass grafting with and without mitral repair were performed in the United States as well, funded by the NIH Cardiothoracic Surgery Network trial. And what they compared and found is that is a similar result, is that patients undergoing coronary artery bypass grafting alone had either persistent moderate regurgitation, or some of them actually had severe or developed severe mitral regurgitation over a 12-month period. However, despite this, the challenge of this study is that the primary takeaway point from this was that there was no difference in mortality at 2 years when you compare coronary artery bypass grafting alone versus mitral repair. So what was determined from the trial is that repairing the mitral valve may be unnecessary in these patients. However, that may be a premature endpoint, meaning that in these patients, they were only followed to 2 years. So how does this data actually compare to the previous data, where I have shown that when patients were longitudinally followed, the ones that had mitral regurgitation would do much worse than the ones who did not. So the first thing is that this is at 2 years. And when we look at this longitudinal follow-up without any intervention, we do see that moderate MR patients and no MR patients actually are not that different. But when we start following them up to 5 years, there would be a significant divergence in this population. And we may see the similar effects in patients who have a revascularization alone, versus those who had mitral valve repair. So in summary, do ventricular approaches or current ventricular approaches to FMR work? I do think they work, but the effect is mostly in reducing FMR than eliminating it. There are some patients who may be responders to all of these therapies, but a significant number of the patients also do not respond to these therapies from a functional mitral regurgitation reduction standpoint. Leading me to wonder, are direct mitral valve interventions necessary in these populations? And what is the efficacy of these interventions? And are there truly opportunities to improve upon these interventions from both a transcatheter and surgical standpoint? I will begin with transcatheter because of the recent approval of the MitraClip technology. It is being increasingly used, and it is likely possible that it may become the first-line interventional therapy in these patients to correct FMR. So to give a brief introduction, the basis of correcting functional MR with the MitraClip system is simply that you can deploy a device that approximates the leaflets at the site of regurgitation, meaning that you are finding where the regurgitation is, clipping the two leaflets together at the site of regurgitation, either with one clip or multiple clips, depending on the size of the regurgitation, resulting in the formation of a double orifice mitral valve, where the regurgitation is now reduced because the site where there was regurgitation is now permanently approximated. On the left bottom, on the right bottom, you would see the tissue bridge that forms after this approximation, resulting in a dual orifice mitral valve. So how does this technology compare to surgery? If you have a functional mitral regurgitation patient, should you actually perform surgery, or should you, if you decide to refer them for an FMR intervention, should you refer them to an interventional technique, or should you refer them to surgery? Currently, there is only one randomized trial which has investigated some aspects of this, which is the Everest trial, which was the first trial that was performed with the MitraClip system, where 279 patients were randomized to either receive the MitraClip system or to receive surgical repair or replacement. One of the biggest challenges with this technique with this trial is that they had considered mitral regurgitation of all etiologies, meaning that 73% of the patients actually were of degenerative mitral regurgitation or primary mitral regurgitation, and only 27% were of functional mitral regurgitation. These recruited patients were then followed with echocardiography for up to 5 years, and the data was presented not too long ago, actually quite a long ago, in 2011. The primary outcome from the trial is on the left side, where you can see that on the left is surgery being better, on the right is MitraClip being better. When you look at the hazard ratios, in the patients who had degenerative mitral regurgitation, or where everything else was normal with the heart, but only the mitral valve was the problem, you see that surgery fared very well. Whereas when you look at the patients who received MitraClip therapy in the functional MR group, there seems to be some early indication that there may be benefit in correcting FMR in these patients using a MitraClip type of approach, which is a transeptal beating heart approach. Based on the study, there was a comparative registry done where these 60 patients who had received MitraClip therapy for functional MR were compared against equivalent registry of patients who had only optimal medical therapy. And what they found was that MitraClip fared much better in terms of overall survival, and also in terms of heart failure hospitalizations compared to optimal medical therapy. So based on this early evidence, the two recent trials, which were recently reported but recruited over the last several years, were designed and reported. The first one is the MITRA-FR trial, which was performed in Europe. And the second is the COAP trial, which is performed in the United States and Canada. Simply, the patients with moderate to severe FMR were recruited to these trials and randomized to receive either MitraClip with guideline-directed medical therapy or guideline-directed medical therapy alone. And the patients were followed to 2 years. In the European arm, the difference was that guideline-directed medical therapy was continually optimized during the trial period, whereas in the COAP data, in the COAP trial, there was a committee that was adjudicating whether medical therapy was optimized prior to their randomization into this trial. So how do the outcomes look? Well, the outcomes actually look quite different between the two trials. In the MITRA-FR trial, which is the European trial, there were no differences in the death or heart failure hospitalizations at 2 years. Whereas in the COAP trial, which is the American trial, there is a very stark, distinct contrast in favor of MitraClip compared to use of guideline-directed medical therapy, as you can see on the right side. When in the COAP trial, when we separate them out into heart failure hospitalizations and mortality separately, you see significant differences. The cumulative heart failure hospitalization rates were significantly lower in the MitraClip group compared to guideline-directed medical therapy alone. And so was there a difference in the mortality favoring MitraClip compared to guideline-directed medical therapy alone. Based on this information, in 2019, MitraClip was was approved by FDA for use in functional mitral regurgitation patients in moderate to severe FMR with a left ventricular ejection fraction of greater than or equal to 20% and less than or equal to 40%, and a left ventricular end systolic dimension less than or equal to 70 millimeters. So what is so similar between the trials, but so different between the trials continues to be a topic of great interest in the community at the moment. The three primary things that are being cited, I have shaded them in different colors. The first criteria that is being cited is that MITRA-FR trial patients had significantly larger ventricles, but lower mitral regurgitation, whereas the COAP trial patients seem to have very smaller ventricles, but significantly larger mitral regurgitation. To put it in simple words, the argument is that the COAP patients had higher MR volume and smaller ventricles, indicating that mitral regurgitation is driving their left ventricular remodeling, which is why the benefit was demonstrated. Whereas in the MITRA-FR, the ventricle was driving the remodeling process, whereas correcting the mitral regurgitation did not seem to have an impact. In a couple of slides, we will actually see whether that is the truth or not. The second area is that guideline, as I mentioned previously, medical therapy was being optimized during the follow-up in MITRA-FR, whereas it was already optimized in the COAP trial. And thirdly, it was shown that the complication rate and failure rate in MITRA-FR was probably greater than in the COAP trial, with the trialists in United States and Canada claiming to have much better operator outcomes with the MitraClip system. Well, what I did was went back and looked at the supplemental data from the COAP trial to understand whether it actually stands. The first thing that stands out is that the study reports an end diastolic volume of about 191 to 194 milliliters. When we look at the diastolic and systolic volumes, that results in a stroke volume of about 58 to 60 milliliters. And by the definition of their recruitment criteria for a regurgitant orifice area of 0.4, you need to have an MR volume of about 40 to 50%. So if you look at the table on the right side, the top row shows the total stroke volume, which is calculated from their data. The second row shows the MR volume, which seems to be expected. So if you subtract those, the forward stroke volume expected in these patients is approximately 5 to 10 ml, which seems quite erroneous. So to get the regurgitant fractions that they had reported, that all these patients had about 40 to 50% MR fraction, with this effective regurgitant orifice area, you would need approximately 300 ml or greater of EDV, whereas what they report is 190. In the MITRA-FR patients, the average EDV was about 290, whereas in COAP, it was not, indicating that maybe there is some underestimation of end diastolic volume in these patients as reported. The second challenge in the COAPT trial is that even though the label states that the COAPT trial criteria was based on American Society of Echocardiography, when you read the fine print, what you understand from the trial is that the adjudication criteria for the severity of MR was significantly divergent from what is defined by the American Society of Echocardiography, as stated here. And the third challenge is that the COAPT trial claims that the outcomes of mitral regurgitation were excellent at 2 years without any significant reduction, without any significant persistence or recurrence of mitral regurgitation. The challenge with that is the scale that was used in grading these patients was a custom developed scale, which is highly subjective because it does not actually take any quantitative methods to quantify the amount of regurgitation that is left behind after mitral regurgitation. And the challenge being that once you put in a mitral clip, you get reflections on ultrasound from these clips, and it is quite challenging to look at Doppler images coming from these valves. The concept which is being cited quite a bit is actually something different, which is that the COAPT trial, as I mentioned, had smaller ventricles, so it has what we call disproportionate MR, and the MITRA FR trial, which has proportionate MR, meaning that MR is proportional to the LV volumes. This is being publicized quite a bit, and already within a year of introducing this topic, there are about 103 publications on PubMed. But when we go back and look at the only data which was published by Maurice Serrano in the early 1990s, whether in ischemic MR there is a relationship or correlation between EDV and EROA, we observe that very clearly there isn't any, indicating that the whole concept of proportionate to disproportionate MR lies on assumption, but not based on data, which has previously been shown to not correlate in the manner that is being assumed in this population. So when we look at the real world experience, what is being shown with MitraClip is that there is elevated gradients after the MitraClip, and that has been shown to predict mortality in a very recent paper published in JAHA. And also at a center, which is a high volume center in Italy, about 42.6% of the patients receiving the MitraClip were having persistent mitral regurgitation. So the biggest challenge with MitraClip is that the anatomy of MitraClip is highly limited in its application, and it is possibly can be applied to patients who have a nice central mitral regurgitation with a very large mitral valve area. However, what about other patients? So we went back to the laboratory and we started developing a different concept, which is instead of clipping the leaflets, we would enhance the leaflet to enable coaptation. So the basic premise is on the left side, is you're looking at a cartoon of a valve with regurgitation, and the cartoon on the right side shows an implant that is attached to the posterior leaflet, where it adds thickness to the leaflet such that there is a bump on the leaflet and a better coaptation shelf. And this coaptation shelf will move with the leaflet in diastole so that it does not cause any functional stenosis. So this concept was deduced to practice by developing this tiny nitinol implant covered in fabric that attaches without any anchors or sutures to the edge of the mitral leaflet. And as the leaflet moves, you can see the device coming into coaptation. And this is a ventricular view you can see on the right side, where you can see the device coming into coaptation at 6 months and providing a much better shelf for coaptation and correction of FMR. This is at explants after 6 months, where we actually see complete covering of the implant with the tissue, and it integrates into the native leaflet as demonstrated with histopathology. And we are now working on taking this technology to first-in-human implants by the end of 2021 as a different approach to trying to correct functional MR without creating the challenges associated with MitraClip system. So now moving on to surgery, I would like to spend a few minutes looking at what happens in surgery. So in patients who are indicated for coronary artery bypass grafting, the need for surgery is obvious. There was a recent trial which compared mitral valve repair to mitral valve replacement in these patients and found that at 2 years, neither repair nor replacement had any different results in terms of mortality, which led surgeons to basically take on the hypothesis that Replacement may be easier in these patients and may reduce the amount of time and is on bypass and is reproducible. So replacement can be a better approach than repair in these patients. If we look at repair, one of the biggest reasons for not adopting repair anymore in the surgical world is that there are high rates of failure and recurrence of mitral regurgitation. Even though the recurrence of mitral regurgitation is always associated with continued LV remodeling despite the repair, if we look closely at the data, what we actually see is that a vast majority of the repairs actually fail within the first 30 days, indicating that it is not the ventricle or continuing disease process which is enabling this remodeling, but it is that the patients coming out of the operating room potentially have that remnant mitral regurgitation that continues to persist if the repair was not done properly. So what we did was we dug deeper again into the supplemental data, and at 24 months, we compared patients who had failure of the repair or death associated with repair versus replacement. The silver lining for repair is that in patients who had mitral repair that was durable, the number of patients who died for other causes, cardiac causes, or continued remodeling were only 9%. Whereas a similar patient population in replacement who did not have any recurrence of mitral regurgitation nor failure of their mitral valves, about 26% of those patients died. And when we look at their left ventricular remodeling, you see that in the replacement group, the LV end systolic volume index was 60.6 compared to the no recurrence repair group, which was 42.7, indicating that a durable repair can elicit the best left ventricular remodeling and potentially improved mortality in these patients. So what we did in the laboratory is try to go back and understand how can we improve the repairs. To understand and improve the repairs, we first needed to understand why do repairs fail. There are several mechanisms. The first simple mechanism is that annuloplasty is not an adequate repair in these patients. The reason is you are deploying a smaller annuloplasty ring to draw the annulus and the leaflets into the mitral orifice, but you're drawing the leaflets away from the two papillary muscles. So often you have these highly tethered geometries where the coaptation after the repair is well within the ventricle than closer to the mitral annulus. The second thing is functional stenosis, where you see a lot of patients who have this oblique geometry of the mitral valve, where you can see that in diastole as well, both of their leaflets are entirely tethered. So we went back to the laboratory to understand how does the extent of reducing the mitral annulus have an impact on the gradient across the valve. So we developed a simple system where we can mount a pig mitral valve and tether it and run constant flow through this system while drawing a Millar catheter across the valve to assess the pressure drop across the valve. We created different degrees of downsizing by using this adjustable annuloplasty system, which is a global adjustable annuloplasty ring to mimic different sizes. But we also developed a new technique based on suggestions from Dr. Guyton, where instead of global downsizing, we can do segmental downsizing by reducing specific parts of the annulus while keeping the rest of the annulus larger in size. We studied the impact of all of these two configurations of global and segmental downsizing on different types of situations of FMR. When we induced FMR by just creating very severe annular dilation, what we saw was that there was a significant rise in the pressure gradient across the valve only at very high amounts of downsizing, which is at about 26. When you had asymmetric tethering with, or symmetric tethering like in dilated cardiomyopathy with annular dilation, what we see is that the tethering of the valve leaflets is such that you would get a significant rise in the gradient across the valve at a much lower downsizing at about size 28. And that persisted in patients who had a type 3B type of asymmetric tethering as well. So when we put all of that data together, what we observed is that the pre-operative angle, opening angle of the anterior and posterior leaflets were highly predictive of the post-operative gradient across the valve after you perform annuloplasty. And this could be used as a planning tool for understanding which patients may need what type of repair. The other aspect is when you have a tethered mitral valve geometry, there is a high possibility that these leaflets are remodeling over time and contributing to repair failure by undergoing thickening and stiffening of the leaflets. So what we had done is we developed a pig model of percutaneous myocardial infarction, which results in functional mitral regurgitation. And after this regurgitation developed, we performed annuloplasty in some animals versus not in other animals. And we let them go for about 3 to 4 months. At termination, what we found is that the leaflets from the sham group, which did not receive any repair, were significantly thinner compared to the group that received annuloplasty, indicating that doing annuloplasty and restoring this coaptation is great, but then we are possibly stretching the leaflets and inducing biological remodeling of these valves. And what we found is that these leaflets tend to have highly elevated transforming growth factor beta, which is associated with fibrosis via changing a shift in the cellular phenotype from a quiescent phenotype, which is normally how valve cells are, to an activated phenotype that synthesizes a lot of extracellular matrix. So based on this, we decided, well, how can we improve the repair? And I will spend no more than a couple of minutes on this and the talk. Instead of using the ring to draw the leaflets into the mitral orifice and away from the papillary muscle tips, we decided why not just use a simple suture to bring the two papillary muscles closer into the mitral orifice first. That would relieve the tethering, and then we would use a larger annuloplasty ring to stabilize the mitral annulus. So the way we had done this is we used a pledgeted suture to draw the two tips of the papillary muscles together, and that would change the whole caudal force distribution and enable better leaflet mobility. So to test this hypothesis, in the bench model that we have, we created pulsatility and also developed these miniature force transducers, which we can mount onto each of the chordae tendineae of the mitral valve and measure the forces under different conditions. This is a summary of the data from a caudal forces. So this dotted black line is the baseline when there was no disease. The dotted orange line is the increased tethering forces in the chordae after the valve was tethered. The red solid line is after undersizing annuloplasty, where we actually see that even though coaptation is restored, the tethering forces. However, when we perform papillary muscle approximation, we saw that we could completely relieve the tethering forces to a large extent, and we could do that with and without annuloplasty with papillary muscle tip approximation alone. When we look at the systolic geometry of the coaptation, what we see is that the coaptation between annuloplasty, approximation, and approximation with annuloplasty are more or less similar. However, the interesting thing, which I alluded to earlier, is that this coaptation occurs much closer to the mitral annular plane with papillary muscle approximation, which you can see with reduced tenting height here, compared to annuloplasty, where the coaptation is well deep in the left ventricle. So based on this data, we performed the so-called preclinical randomized trial, I would say. It's not really randomized because it's very tough to randomize preclinical animal models. But we induced functional MR, we performed different repairs in a set of about 30 animals, and we let them go to 6 months and performed cardiac MRI on these animals. So we compared sham to annuloplasty, annuloplasty with papillary tip approximation, and papillary muscle tip approximation alone. And what we found is that the anterior leaflet mobility was significantly improved at the chronic termination time point in the animals that had papillary muscle tip approximation, whereas with reduced tenting area. And the posterior results were similar as well, where we could see that the posterior leaflet mobility was significantly better in the animals that received papillary muscle tip approximation. And finally, when we looked at the biology of these not so tethered valves after papillary muscle approximation, we found that it actually does extremely well in inhibiting any fibrosis and extracellular matrix remodeling of these leaflets, indicating that we could potentially preserve the biology of these valves by reducing the tethering as well. So in summary, what do I think about functional MR surgery based on the evidence is that both replacement and repair are viable and safe options for correcting FMR. Replacement may be easier and quicker, but a durable repair is likely to yield the best reverse remodeling. and surgical repairs need to be optimized, and they are continually optimized now. So we are currently doing an NIH-funded trial to test this papillary muscle approximation study where Dr. Guyton is recruiting patients on our behalf to compare annuloplasty with this kind of bottom-up approach of reconstructing the valve. In summary, about the 3 points that form the outline of my talk. Does functional mitral regurgitation contribute to worsening heart failure? I think it does. Even though it is a ventricular problem, mitral regurgitation only worsens the ventricular problem, but does not really enhance it in any favorable way. Do first-line ventricular approaches to FMR work? They do to an extent in some patients, but not in all patients. Do mitral valve approaches to FMR work? Transcatheter approaches are definitely emerging, but I think there is a need for independent and rigorous analysis of interpretation of the data prior to widespread application of these technologies. But there are several other technologies coming as well. And surgery, we do think, has acceptable risk in these patients, and that is becoming more evident because a lot of patients who are initially deemed non-surgical candidates for receiving MitraClip ultimately end up receiving a repeat surgery because their MitraClip fails, and they survive the surgery quite well after several years later of having heart failure, indicating that maybe the concept around surgical risk could be redefined, and more number of patients who have functional MR could also be referred to surgery and not just transcatheter approaches. And that is a topic that continues to evolve over time. So with that, I would like to end my talk, and I have several people to acknowledge, but in the short period of time, my laboratory and all the clinical investigators that I have had the opportunity to work with at different hospitals, especially at Midtown, and all the funding sources that continue to support our work in the laboratory and help us work on this topic of functional mitral regurgitation. So with that, I'll end, and I'll be happy to take any questions. Thank you.
The preceding program is copyrighted by Emory University.